Thanks very much, Niall. Thank you, both of you, for asking me to speak. I find myself in the invidious position of looking at an audience, most of whom know far more about the subject than I do, which is a slightly sort of strange way of starting a talk. But anyway, this one's on diastolic function and dysfunction. I'm not in bed with anybody I shouldn't be. I'm going to talk to you, if I may, about really three aspects of this subject. And firstly, does diastolic function and dysfunction predict outcome? Does manipulating it make any difference? And then I'm going to get on to why and how do we assess diastolic function. Now, I'm fully aware in that bit, and obviously I can't change the talk at this point, that some of you will know all of this. So I apologize for that if that's the case. Now, we know well that mild diastolic dysfunction is a normal feature of old age, and that 60% of those aged over 70 have a degree of abnormal diastolic function. Well, hang on a sec. I mean, 60% of people at that age have got so-called abnormal diastolic function. That makes baldness abnormal too, because fewer people are bald than have abnormal diastolic function. So you can't regard something which is prevalent in such a large section of the population as abnormal. It's only abnormal in a physiological sense. We know that over half of people who have heart failure have an ejection fraction over 50%, condition that's become known as heart failure with preserved ejection fraction. I think the cardiologists also accept that there are no yet known treatments of clear benefit for diastolic dysfunction. There are certainly treatments for systolic dysfunction, but there are no treatments for diastolic dysfunction, although I do understand that PDE5 inhibitors like sildenafil are showing promise in the treatment of diastolic dysfunction. Can you all hear me, by the way? Yeah? No problems? I say that because I'm deaf. So the first question we come to is, does abnormal diastolic function predict outcome in cardiac surgery? So just 2 or 3 studies on that. This one from Yoon in the Annals of Thoracic Surgery last year, and I want you to concentrate on the numbers in blue. Along the top, you can see diastolic function, which they graded as normal, mildly abnormal, moderately abnormal, and severely abnormal with restrictive filling. And if you have a look at the restrictive filling column, you'll see that the numbers who required IPPV for more than 24 hours, developed respiratory failure, renal failure, or had a hospital length of stay of greater than 12 days were enormously greater than in the subsection of the population who don't have restrictive filling. Well, I guess that's no great surprise, and those are highly significant figures. And I think what that's telling us is people with bad hearts are more difficult to get through heart surgery. Whether it specifically relates to diastolic dysfunction is a different matter, because it is very often the case that severe diastolic dysfunction goes along with systolic dysfunction. If we look at this paper from Lee in anesthesiology this year, looking at outcomes following OPCAB, subdivided by the E over E prime ratio, we can see that in the immediate post-op period, ICU length of stay and hospital length of stay are influenced by your E over E prime ratio, that your 30-day incidence of major adverse cardiac events, major arrhythmia or cardiac death, are significantly increased, and your 1-year complication rate is significantly increased if you have an E over E prime ratio greater than 15, and the cardiologists know this well. This paper from Swaminathan looks at 5-year, I think Kaplan-Meier plot of 5-year survival after surgery. And again, you can see that those who've got grade 3 abnormal diastolic dysfunction, in other words, restrictive filling, do much less well than patients with better diastolic function. So does abnormal diastolic function predict outcome? Well, quite possibly, yes, it does. And I think what it says is that if you've got a bad heart, you're probably not going to live so long as if you've got a good heart. More thorny, does an attempt at managing diastolic function alter outcome? And the sort of prototypical drug which people think about in the context of diastolic function is Levosimendan. Now, I've never used Levosimendan, and one of the reasons I've never used it is because we can't afford it. But it is perhaps the preeminent lucitrope. This paper from De Hert and Co., very small sample, but 30 patients, 15 of whom received milrinone and 15 of whom received Levosimendan. There were no differences in preoperative ejection fractions or Euroscores in these patients, but they all had very poor left ventricular function with EFs less than 30%. All of them received abutamine at 5 mics a kilo per minute. Actually, in the paper, they wrote 5 milligrams per kilo per minute. I hope that was a misprint, because it's a rather veterinary dose. It might be appropriate for a rhino, but I'm not sure it's good for a human. And they were given noradrenaline if their mean arterial pressure was below 60. What were the outcomes? Well, the Levosimendan group had a better stroke volume index between 12 and 48 hours post-op, but not for the first 12 hours. They had shorter intubation times, and their total doses of inotrope and vasopressor were less, but there were no differences in mortality, troponin release, major adverse cardiac events, length of stay. The only noteworthy thing was that there were 3 deaths in the milrinone group, but this didn't achieve statistical significance, so it could just be a random, feature. This meta-analysis from Landoni 2 years ago of Levosimendan versus control, which I'm pretty sure in this paper was milrinone, or in most of these studies was milrinone, shows a small reduction in overall mortality in the Levosimendan group, but the actual mortality drop is from 12.7% to 4.7%. Now, the papers in this meta-analysis were a rather sort of mixed bag. About 3 of them, 3 out of the sort of 10, were patients with poor LV ejection fractions, less than 30%. But some of these papers were normal hearts, and some of them were routine valve surgery. And I would contend to you that 12.7% is a pretty high mortality for a mixed bag of heart surgery, certainly by our standards that I'm aware of in the UK. And so I have to be slightly doubtful about the veracity of this meta-analysis in the context of UK heart surgery. A more recent one from King's College in London, from Maharaj and Metaxa, again shows similar trends of slight improvements with Levosimendan. And perhaps it's noteworthy that the one paper, which is the Levin paper, which is about 10 down from the top, is the only one with any number of patients in it. All of these are extremely small studies. The Levin study's got, I think, something like 140 patients in it. And it is the one, it is almost the only one which shows a significant reduction with Levosimendan. But I think we have to be pretty doubtful. An awful lot of these publications show no improvement with the use of Levosimendan. So I think we have to be really quite circumspect that attempts to modify diastolic function during surgery have any clear effect on outcome, and that a large randomized controlled trial is needed. So how and why do we measure diastolic function? Why do we measure diastolic function? Well, I measure it for 2 reasons. The first of which is to attempt to derive some sort of estimate of left atrial pressure. Now, it's well accepted in cardiological circles that echo correlates of diastolic function do give you quite a good idea of left atrial pressure. There's a certain amount of doubt as to whether that applies during anesthesia and IPPV, and there's a paper in last month's, or might be the month before's, anesthesia from Royce and Co. In Australia, which says that the equations which are used to derive left atrial pressure from indices of diastolic function do not correlate very well with wedge pressure as measured by a Swan-Ganz catheter. So there is some doubt as to whether measurement of left atrial pressure from diastolic function indices during surgery is completely valid, but I'm pretty certain that if you take all the information that you can get from an echo and put it all together, you can usually come out with a pretty coherent explanation and a pretty good idea of roughly what the left atrial pressure is, at least to within a few relevant millimeters of mercury. And the second reason we might want to measure diastolic function is perhaps to try and modify it, but I think there are, as I've already alluded to, questions about doing that. So really the reason I think why we look at diastole is mainly to measure left atrial pressure. How do we do it? Well, there are a number of echo features, both 2D and Doppler, that you can use. Importantly, some of them are load dependent. Left atrial size, and I cannot stress to you enough that measuring left atrial size, I'm sorry to patronize those of you who all know this, but measuring left atrial size is a hugely important thing to do. Actually, TOE is not the best way of doing it. TT is much better for measuring left atrial size, and the reason for that is very often the size of the atrium simply are not included in your pie slice of echo. But left atrial size is a really important measurement. If you have a normal or small left atrium, it is almost impossible for you to have any degree of significant chronic left heart disease, whether it's LV disease or mitral valve disease. So a small left atrium really tells you you've got a low left atrial pressure. But it is a load-dependent measurement, and many of you will have seen that an enlarged left atrium pre-bypass with a bit of inotrope and some decent surgery will come back to a smaller left atrium post-bypass. And so there is undoubtedly a degree of load dependence about left atrial size. It is not a fixed property. Similarly, mitral Doppler velocities and pulmonary vein velocities are dependent on left atrial pressure. And although I've never done it, I do believe it to be the case that if you overfill a normal heart enough, you can give it a transmitral picture of restrictive filling just by overfilling a normal heart. So transmitral Doppler velocities are really, as much as anything, a feature or a correlate of left atrial pressure. The more you fill the heart, the more it goes towards restrictive filling. But we do also have some load-independent indices. The E-wave propagation velocity, which I'll talk about a little bit later, I think it's a very difficult measurement to make well. I think it is a measurement which at times has the capacity to be a bit of a random number generator. But it is used, and it is talked about quite a lot as a load-independent index in the literature. And then mitral annular tissue velocities, tissue Doppler. Now, it's very important to remember that you can't always measure all of these things. Your machine software may not have the capability, or you may not have good enough views. With any Doppler measurement, you have to line the direction of motion up with the Doppler beam. And a bad measurement is worse than no measurement at all, because it makes you do things from dodgy information. And remember, too, that you cannot easily assess diastolic function in somebody with significant mitral valve disease, or for that matter, significant aortic regurgitation, particularly acute AR. It's very, very difficult to tell much about diastole in those circumstances. So to go through diastole now, remember there are 4 phases. You all know that. We're really interested mainly in phases 2 and 4, early diastolic filling and atrial systole. The normal heart, as you know, most of its ventricular filling takes place in early diastole, and LV suction is very important. Diastole is an active energy-consuming process, and the normal LV generates a highly significant degree of suction, to the extent that I believe it is entirely possible for a young heart, the left ventricle of a young heart, to fill when the left atrial pressure is 0. And the reason for that is left ventricular suction. Poor hearts, those with advanced diastolic dysfunction, lose their ability to suck blood from the atrium into the ventricle. And so really I want to get quite what I find a useful concept over to you, which is that a healthy heart in diastole, the left ventricle sucks blood out of a low pressure left atrium, where in an unhealthy heart, a high pressure left atrium pushes blood into an unhealthy ventricle. So the mitral velocities may look similar, but the actual mechanics of what are going on are completely different. And this slide from an old paper from Ling and Co. Just sort of shows you at the top a normal ventricle and at the bottom a failing ventricle, and that the pressure gradients right out to the apex of the ventricle, the negative pressure gradients in diastole, are very well maintained. And that is the reason why propagation velocity, which is the rate of propagation of the E wave out towards the apex of the ventricle, is so much higher in good hearts than in poor hearts. So in a poor left ventricle, it's really only about the proximal third or half of the ventricle which is filling during diastole. The apex really does very, very little. Now, you'll recognize this, the cardiac cycle. And I'm going to show you these patterns in a normal situation and in abnormal situations. Now, the point that I like to try and make here, if you look at the red tracing, which of course is left ventricular pressure, is that the rate of descent of left ventricular pressure in early diastole between A2 and the point of the mitral valve opening and beyond is very, very rapid, and the pressure generated, the pressure in the left ventricle at that point, at the end of that descent in early diastole, is really quite low. So although left atrial pressure in this normal heart is low, a decent pressure gradient is created, aided and abetted by the LV suction, and so most of the transmitral flow, which you see in green at the bottom, takes place in early diastole. We then have a period of diastasis if heart rate is less than 70, in which the pressures between the atrium and the ventricle have equalized and no flow takes place, and then the atrium contracts and a little bit more blood passes into the ventricle. Now, the reason not a lot more blood passes into the ventricle is because the atrium at this point, I mean, it obeys Starling's law just like a ventricle does, and the atrium at this point is already relatively empty, so it doesn't contribute much to left ventricular filling. So it's a funny irony that a heart which really doesn't need much atrial function is a heart that always has atrial function, because good hearts don't go into atrial fibrillation. And this is what it looks like on transmitral Doppler with a normal E-wave velocity, normal A-wave velocity, an EA ratio of 1.5, the normal range is about 1.5 to 2, and a deceleration time between 160 and 200 milliseconds. So that's an entirely normal transmitral pattern. When we get on to abnormalities of diastolic function, conventionally we split this into two groups, as you know, mild and severe. The hallmarks of which are that in mild dysfunction, relaxation of the left ventricle is prolonged, but LV stiffness, intrinsic stiffness, is only very mildly increased, if indeed it's increased at all, whereas in severe dysfunction, relaxation is more prolonged. But in addition to that, LV stiffness is markedly increased. What cause these abnormalities of diastolic function? Well, I've already mentioned age, so I presume that means me, because I'm over 60. LVH, left bundle branch block, and acute ischemia are the classic causes of mild diastolic dysfunction. Now, left bundle branch block, of course, is interesting because left bundle branch block causes discoordinate systole. And it's quite possibly, and indeed many people believe this to be the case, that the reason diastolic function appears to be abnormal in people with left bundle branch block, and probably other conditions too, is because systole is discoordinate. And systole continues beyond the closure of the aortic valve. And if that is occurring, it's inevitable that the beginning of diastole is going to be impaired and disturbed in its function. So some abnormal diastolic function actually is about abnormal systolic function, continuing on into the diastolic period. Now, in these people, left atrial pressure is only mildly elevated. This movie shows you a reasonably normal LV on the left, which you can see expands at reasonable speed in diastole, and the one on the right is an aortic stenotic ventricle, and you can just see by looking at it that it expands very slowly in diastole. You really don't need to make measurements about this ventricle to know that it's got abnormal relaxation. Its relaxation is very prolonged. Now, what happens from the echo point of view? On this slide, that the dashed yellow left ventricular pressure in diastole is the normal picture. So you can see that the rate of decline of pressure in the ventricle in this heart with mildly abnormal diastolic function is reduced, and the maximum negative pressure generated, or the maximum, the sort of trough of diastolic pressure generated in this ventricle, is not so low as it was in the normal ventricle. And therefore, a smaller amount of blood passes through the mitral valve in early diastole, and because the atrium is much fuller at the point at which it comes to contract, far more blood passes through during atrial systole. And this is what it looks like on echo. What we see is a smaller E wave, a larger A wave, and a deceleration time which is over 200 milliseconds. So this is absolutely typical of a ventricle which is relaxing too slowly, but does not have a particularly high left atrial pressure. Coming on to severe dysfunction, what we now have is a combination of prolonged relaxation and increased stiffness. Causes will be obvious ones to you: left ventricular failure, restrictive cardiomyopathy, and indeed probably overfilling, where we now have a ventricle which has lost its compliance. Now, in this subgroup, left atrial pressure is markedly raised. And here you have an example of the same normal ventricle on the left and one on the right. And I don't know whether you can see it, but I certainly get the sense with this ventricle on the right that it expands very rapidly in early diastole and then actually comes to a grinding halt. It fails to expand any further, and this is a sort of typical restrictive filling ventricle. Now, left atrial pressure is markedly up now compared with the normal values, which again is the yellow dashed line, which I hope you can see. And although the ventricle relaxes slowly and doesn't generate a very low trough pressure in early diastole, because left atrial pressure is now so high, a large pressure gradient is generated and therefore a big E wave. Because the ventricle is stiff, that inrush of blood into the LV results in a rapid increase in LV pressure during diastole, so that at the point where the atrium comes to contract, it's attempting to contract into a ventricle which already has a high diastolic pressure into it. So not surprisingly, the LV does not contribute much to forward fill. The LA does not contribute much to forward filling in patients in this situation. And instead, a lot of the blood in the left atrium gets pumped backwards into the pulmonary veins. This is what it looks like: a very tall E wave, usually with a high velocity, a small A wave, a high EA ratio, in this case 3.6, and a short deceleration time, under 160 milliseconds. So this is absolutely typical restrictive filling. So it will have become obvious to you now that we have a pattern of change as you go through life and as you enter heart disease, from the young heart with a low left atrial pressure on the left of the screen, which has very active suction, and therefore the E wave is huge and the A wave tiny, into normal adulthood, young adulthood, where the E wave is a bit smaller and the A wave a bit bigger, and the ventricle doesn't sound quite as well. And then as we get into old age or ventricular hypertrophy, we see prolonged relaxation with a small E and a big A, EA reversal. And then moving over to the right of the screen, we enter the era of heart failure and restrictive filling, which in terms of transmitral Doppler looks exactly like a kid's heart. And of course, it will be obvious that as you move from prolonged relaxation through pseudo-normal filling to restrictive filling with progressively increasing left atrial pressure, you go through a pattern of normality again, which is why the term pseudo-normality came into being. I'm going to move on now to the pulmonary vein and pulmonary venous patterns of filling. As most of you know, there are three components of the pulmonary venous wave: S, D, and A. S being forward flow up the pulmonary vein during ventricular systole, largely caused by mitral annular descent, and we'll see that in a sec. The A wave is the equivalent of the transmitral E wave and is diastolic filling of the left atrium from the pulmonary vein while the atrium is emptying into the left ventricle. And then the AR wave, atrial reversal wave, which is the result of atrial systole. And under normal circumstances, the S wave and the D wave are of about equal sizes, and the AR wave is small and is significantly shorter than the transmitral A wave. Coming on to prolonged relaxation, remembering that the D wave, which is the middle of these three waves, correlates with the transmitral E. If the transmitral E is small, then the pulmonary venous D is going to be small. And so what we see is a bigger S and a smaller D, but a slightly larger atrial reversal wave, still shorter than the transmitral A, but slightly larger because left atrial pressure is a little bit higher. As we move progressively towards restrictive filling, and the transmitral E wave gets progressively bigger again, so the pulmonary venous D gets bigger again with it. So the S gets smaller and the D gets bigger, a phenomenon we call S blunting. And the AR wave below the line gets progressively larger for the reason that I mentioned earlier, which is at the point the atrium contracts, the pressure in the LV in mid-diastole now, or late diastole, is high. Therefore, the atrium, unless it's a very dysfunctional atrium, or AF, of course, pushes a lot of blood now backwards up the pulmonary vein, and the duration of that AR wave becomes longer than the duration of the mitral A wave, and its velocity, when you get into restrictive filling, is more than 35 centimeters per second. It's actually quite a useful measurement to make. And this is what these patterns look like. On the left, normal, with S roughly equal to D and a small AR. On the right at the top, prolonged relaxation with a big S, a small d, and a slightly larger AR. And at the bottom, restrictive filling with a tiny s, a huge D, and a very big AR. So pulmonary venous waves can be helpful here, although still load dependent. Moving on to the load-independent indices, just a couple more issues. And the first is measuring propagation velocity. It takes a bit of doing this. You have to turn the aliasing velocity down so that the aliasing velocity is lower than the E-wave velocity. It helps to have a long, narrow color sector, as you can see in the icon at the top that I've got. It's best to zoom in. You then switch on color M mode and turn the sweep speed to maximum. And by doing all of those things, you increase the signal-to-noise ratio of this measurement. And what you're measuring is the gradient of the first alias, where blue becomes orange. That's why you have to turn the aliasing velocity down. A normal value, a truly normal value, I think probably is more than about 50 centimeters per second. Some people take 45, some people take 55, but it's around 50. This is clearly a highly abnormal heart. The propagation velocity is only about 25 centimeters per second. Now, there is an equation, Garcia's equation, which allows you to calculate left atrial pressure from this, which is the LAP is the E velocity over the propagation velocity times 5.27 plus 4.6. And that is one way of deriving an estimate of left atrial pressure. It isn't the easiest way. There is an easier way, but it depends on what technology you've got. Now, finally, the last thing we can do in assessing diastolic function is to look at the mitral annular tissue velocity. Now, if you have a look very closely at this heart, you can see that the apex stays absolutely still. And it's the base of the heart that moves up and down. The mitral annulus is going up and down like a piston, up in diastole and down in systole. It goes down as a result of systolic contraction and up as a result of elastic recoil. And we can measure the velocity at which that downwards and upwards movement of the mitral annulus occurs. And we do that by putting our pulse wave Doppler probe into the lateral mitral annulus and simply hitting tissue Doppler, provided you've got it on your machine. And we come up with three waves which are correlates of blood velocity waves. The E prime, which is the correlate of the transmitral E, but it's in the opposite direction because as mitral flow goes down into the LV on TOE, the annulus is coming up. And there's similarly an A prime, which is the equivalent of the A wave. And there's an S prime, which is to do with systolic function and can give you an index of how good systolic function is. Now, if you have a look at the two of these, we've got a normal heart on the left and a restrictive filling heart on the right. And although the waves don't look actually terribly different, look at the actual velocities. In the normal heart, the E velocity is 11.5 centimeters per second, whereas in the heart with restrictive filling on the right, the E wave velocity is 5.2 centimeters per second. A normal value over 11 is definitely normal. Over 8 is reasonably normal, but anything under 8 is abnormal. And so the E prime velocity is pretty much load independent assessment of diastolic function. Now, the easiest way I know of getting an estimate of left atrial pressure is just taking the E wave velocity dividing it by the E prime and adding 4. And that gives you a reasonable estimate of left atrial pressure. So just to summarize, I think it's probably reasonable to say that diastolic dysfunction is definitely common and certainly may predict short and long-term outcome after cardiac surgery. I don't think as yet there's any good evidence that attempts to modify it affect outcome. I think it's very important that you take all the information you can get off an echo. Never rely on one piece of information. Get every piece of good information you can and try and make a coherent explanation of what's going on. I think you can get a reasonable but not 100% accurate of left atrial pressure. And if you want a good review on the subject, there was, I think, an excellent one in Anesthesia and Analgesia in September last year. So if you want to follow up this subject, that's quite a good reference. I thank you very much for your attention.
Thank you, Mark. Another excellent talk on diastolic function. I'll ask a question. Sean, in his excellent talk, mentioned that he predicts whether he's going to use inotropes or not if he sees impaired systolic function. Will that influence you if you see impaired diastolic function?
Only in a very loose way, really. I mean, if you've got a heart that doesn't look very nice, which I have to say these days is a great rarity, and I'm perfectly happy to come off bypass at 60 if the LV is looking fine. If you've got a heart that's not looking very nice, you're going to tend to get out an inotrope, and it rather depends what your first choice of inotrope is as to which one I think you're going to get out. Would I specifically treat diastolic function? I'm not sure that I would. No, I mean, I just don't think we're that scientific and accurate in theatre. And I'm not sure that there's any evidence that suggests that I should be specifically treating diastolic function. So I think most of us tend to eyeball the heart and say, does this heart look happy? And if it does, you leave it be. And you should leave it be, because if you wave drugs at a heart that's working perfectly well, in my opinion, you're treating nobody other than yourself. So if the heart's happy, leave it be. If it's unhappy, yes, treat it. I don't know if that answers the question.
Have we any more questions? Great. Thank you, Mark.